aguda alcoólica e desde fevereiro de 2012 a econoscopia demonstra um volumoso pseudocisto de pâncreas. Temos a imagem. Então, na verdade, os senhores observam que é um cisto realmente bastante grande e tem pelo menos 6, 7 centímetros por essa imagem. A próxima imagem, por favor. Próximo slide. Hi, Ken.
Hi. So, we're going to show pseudocyst drainage. This is a very nice case. The first thing you need to determine is whether the cyst is a good candidate for endoscopic drainage. And there are 3 things you want to look at. The first thing you want to look at is the contents of the cyst. And you can see that the contents here look mainly liquid. It's a ground glass appearance, so I think that the liquid is rather thick. It could even be infected, but it does look like it's mainly liquid. And now we'll take a look at the second component, which is the wall. You want to look at the wall here and make sure that the wall looks reasonably mature, reasonably well demarcated. And the final thing you want to look at here is the apposition of the cyst with the gastric wall. So we're going to magnify a little bit so that you can see this. And you're looking here at the space, and Dalton, if you can measure the distance between the gastric wall and the cyst, and generally we don't want this distance to be more than 1 centimeter. Now the reason why that is because we only want to drain cysts that are adherent or reasonably adherent to the bowel wall. So it's 3.3 millimeters, so it's not very large, and you can see that the wall layers look reasonably fused together. The other thing we're going to use is Doppler and make sure there are no vessels interposed. You can see there's some vessels outside there, but there are no vessels interposed between the stomach wall and the cyst. So I think we can conclude now that this is a good candidate for cyst drainage. Now Dalton, if you could measure out the cyst so we can see how large the cyst is. So we'll start in 1 dimension here, 1 cross, and then the other dimension across. So we see it's 8.6 centimeters by 10.6. Let's talk about how we drain these cysts, and we use what's called the Seldinger technique. And the conventional method is we start with the FNA needle. We're going to pass the FNA needle, the 19 gauge, into the cyst. We're going to aspirate a little bit of fluid and send that off for analysis for CEA and amylase and cytology. That's always in the routine, because it's always possible that we may misinterpret this to be a pseudocyst when in fact it's a neoplastic cyst, a mucinous cystadenoma. Then afterwards we will inject contrast. Now we're not going to do that today because we have no X-ray, and the purpose of this demonstration is to show you how we can drain these cysts without X-ray at all. But the second step would normally be, in X-ray, inject contrast, define the anatomy of the cyst. And then the next step would be to pass the guide wire into the cyst. Then you need to dilate the tract, and you can dilate the tract with cautery. You can use a cystotome to do that, or you can use a balloon. So typically what we'll do in the United States, we don't have the smaller cystotome, only the 10 French, so we will usually go to balloon dilation over the wire next. But sometimes that's difficult because of the step off between the wire and the balloon, and that's why that middle step, cystotome first, then balloon dilation, is often performed. What I'm using now to show you, because of time constraint, is the hot Axios system, and we're going to start by luer locking this to the endoscope like this. And the idea here is to be able to use cautery. There's a very fine bougie tip. It's very finely tapered at the tip, and it uses cautery. The idea is to get into the cyst with cautery. This is much finer than the cystotome. It's a very fine tip and a different design, but it does use cautery. Enter into the cyst and immediately place the stent. So the idea here is that everything is done under ultrasound guidance. Place the stent. After the stent is placed, then you go through the stent and do the entire examination endoscopically and not radiologically. All right, so the first stent, this has 2 different components. This is the first, there are 2 hubs, hub 1 and hub 2. This first distal part here advances the sheath forward. This more proximal part deploys the device, the stent. And you deploy the distal flange first, and it locks. And then when you're in good position, you deploy the proximal flange. So each of the flanges, distal and proximal, are deployed independent of one another. And what's important is that everything is controlled by the operator just the same way that you do F&A. There are two locks here as safety guards, okay? So the first thing I'm going to do is unlock the sheath. And I can advance the sheath like this, pushing it forward. And we should see that on ultrasound. Do you see it at the top here on the ultrasound? It's very radiodense. And what I'm doing is using cautery and just advancing in like this. And I'm inside because it's finely tapered. And the cautery is only at the tip. Now once I'm inside, I'm going to lock here. Lock this so this part doesn't move. We're going to take off this safety pin here, discard it. Now I'm going to unlock the proximal hub. This is for the device deployment, the sheath deployment. And the first step is just to pull back and look on the EUS. Look on the EUS, and you will see the stent deploy. Do you see it here? It's deployed. The flange is fully deployed. Now I'm going to switch to the endoscopic view. So I'm going to have, you can see only the distal flange and the proximal flange will not deploy. Now we're going to do the rest under endoscopic guidance. You could do it all under EUS guidance, but for the beginner, it's better to do this in two steps: ultrasound guidance for the distal flange, and then for the proximal flange, do it under the endoscopic guidance. So we're going to put air inside, and we're going to look now for the site, for the catheter, and you can see here it is white. We're going to pull back till we see the black. Do you see the black mark here? Okay, it's ready. I've unlocked, and now I'm going to release the proximal flange. You see it coming? It's all very controlled, very controlled. Yeah. And now I can push the sheath forward, and there it's in place, perfect in position.
Very nice job.
Takes only a few minutes, and it's very controlled and draining now nicely. So you can see the proximal flange. Because we have two flanges, proximal and distal, that are lumen opposing, we don't have to worry about accidentally dislodging the stent as we advance into the scope, into the cyst. So the idea today is use the stent not only for the drainage, but as a port to do endoscopic intervention in the extraintestinal lumen. So it doesn't matter if you're in a pseudocyst or the gallbladder or the bile duct, everything becomes a continuity, a continuum with the GI tract. It's just another side street. You have the main highway, the GI tract, and you have side streets that go to pseudocyst or gallbladder or bile duct.
That's why you called anastomotic stent, right?
That's why it's called an anastomotic stent, right. So you see the stent here at the EUS at the top, and we'll just mag in there. See it? There's the stent hugging the lumen of the wall of the cyst. See, up here.
Yeah.
And going to the other side in the stomach. Stomach, cyst. Yeah. Cyst, stomach. Okay? Here. So what I do always is afterwards I irrigate. Irrigate, what I call vigorous irrigation, and clean it out just like you treat a wound debridement principle. And then I put H2O2 at the end, hydrogen peroxide at the very end. So a very nice image of the cyst here. You can see some of the debris. And we're using the stent as a port. So you can do everything you normally do in the GI tract, you can do inside of the cyst. So it makes it very safe now to do cystoscopy. It makes it very safe to go into the extra luminal space. So now we'll do some irrigation just to demonstrate that. Here. Good. So now this you see we're just irrigating, and what I usually use is a therapeutic channel, so I can irrigate through the working channel, has an extra irrigation port, and then suction at the same time, just to make sure everything is very clean. And then at the very end, I put hydrogen peroxide in. 3% hydrogen peroxide, diluted 50-50, and I put 20 millimeters inside. And then you see it all bubble up, and that keeps the cyst nice and clean. The other thing I do is I tell the patient to not take any PPI for 1 month. No PPI, because I want to keep this sterile. I want the stomach acid to maintain a sterile environment. And finally, I also put the patient on antibiotics for at least 1 week. Okay, so this all looks very nice, and I'll start to come out now, and then you have a final view. You see there's no risk of bleeding from the dilation. The limitations, the problem with pseudocyst drainage has been the complications related to dilation. Dilation causes perforation. Sometimes you think they're adherent, the cyst and the wall of the stomach, but it's not really very adherent, adequately adherent. And as you dilate, the walls separate from one another. And the other complication is bleeding. Now, I've had patients who I personally had to wheel into the OR that were exsanguinating from arterial bleeding. So we've eliminated the risk of perforation by eliminating dilation completely. We've eliminated any risk of leakage because we entered the cyst and immediately placed the stent. So we're doing nothing over the guide wire, everything in one step. And we've eliminated any risk of the bleeding because we have a fully covered stent here that, with the expansion of the stent, creates tamponade. So even if with the dilation you tear a vessel, you have the tamponade effect. And a beautiful view inside. And I would recommend in 1 month he come back for a CT scan, confirm that the cyst is collapsed and gone, and then Dalton can go and put the snare around the end. So it's very easy to remove. Take a big snare and put it around, or take a forceps, a rat tooth forceps, grab the end and just pull it out. Comes right out.
Ken, when you push the endoscope through into the cyst, is there a risk to move this stent because you just put it?
No, very little, because the flanges are holding the walls together. So of course you have to go cautiously if you have friction. So you want to dilate to a diameter greater than the diameter of your scope.
Okay.
That's important.
There's another question from the internet about the follow-up.
Follow-up, yes. 1 month CT scan,
Okay.
and then if the cyst is gone, then remove the stent, and you'll have a nice mature tract that will gradually close down.
Thank you.
Yes.